this presentation, we're going to talk about the preliminary work that's done before the surgery it's done. And we're going to talk about diagnostic wax, diagnostic cast, surgical stents, and radiographic stents. So when a patient comes to um, the dentist, first the dentist take a visual look at the patient's mouth to see what's going on in there. Then they take an X-ray to see, the what's going on with the bone and the roots of the natural teeth, what's going on with the sides that are missing the natural teeth, the gums, etc. And also at the same visit, the doctor might take what's called a preliminary impression um, and that can be taken with an alginate impression. And they send us that impression in the laboratory to put up an impression and fabricate what's called a diagnostic cast. And the diagnostic cast has multiple purposes. One of the purposes is for the doctor to look at it and to see in more detail what's going on in the patient's mouth. Sometimes it's very hard to see very well what's going on in terms of um, the landmarks like the sulcus or the extent of the gum, especially in the posterior area. So, excuse me, having diagnostic cast allows the dentist to have a better vision of the patient state. Also, the diagnostic wax up can be used for us to evaluate what kind of work we might do later on in the process, but also to fabricate the custom tray if the doctor desires to have a custom tray, and to fabricate the provisional and restoration and the surgical stent. So those are the preliminary steps that are done before the surgery it's even taking place. So what the diagnostic wax up tells the dentist, tells the occlusal vertical dimension. So the doctor puts the cast together and see, okay, this is how the patient bites down. Also, they can look at the maxillary anterior tooth position. If the patient has some missing teeth, usually the natural teeth, they start to move towards the midline. So if there is any shift or movement or the natural teeth, that can affect the area of the implant should be placed. The occlusal planes, so that's very important because if a patient has missing teeth on one arch, on the opposing arch where the patient has natural teeth, that those teeth, because they have nothing to occlude with, they're gonna erupt, so they're gonna be longer than the other natural teeth, and therefore that's going to affect our restoration, because now we have to take into account that a tooth is a little bit longer than the other teeth, so therefore our restoration has to be shorter. Eccentric occlusion is very important because that gives us an idea how much we can how much force the patient can put on the implant. Okay, so if a patient has a strong bite, and we can see this on the natural teeth. If the patient has natural teeth and we see that the teeth are worn out, that's an indication that the patient has a bruxism. And therefore, when we're going to design our final restoration, maybe we want to make the restoration of occlusion or maybe a light occlusion. So this way, when the patient bites down, doesn't put too much force on the implant. Number of the missing teeth and position, that's also very important because, like I said, the natural teeth, when they have a empty space next to them, they start to shift a little bit. So that's changing also the planning of the surgery and also the way we're going to design the final restoration. Maxillomandibular arch relationship. So if a patient is in crossbite, again, we have to be aware of this. And evaluation of the bone and the soft tissue. So those are all the factors that the doctor has to take in account, and actually he can look at the diagnostic cast and see the areas where problems might take place. So another important aspect of doing this type of diagnostic cast is that the dentist might ask us to do a diagnostic wax-up. So for instance, if a patient is missing the 6 upper anteriors, right? The doctor may ask us to do a diagnostic wax-up to do, to see how the patient will look with the temporary restoration, and then that can be used for the final restoration as a guide how to design the final restoration. The value of the diagnostic cast or study models is critical in all dentistry, and especially for when we're talking about dental implants. Like we said, many patients have partially edentulous area for a longer period of time, and that means that the bone it's shrank, it's resorbed, and there are changes in the oral setting of the teeth, the natural teeth, if there are any there. Like I said, the teeth, they might move. And also sometimes a doctor might prescribe orthodontic treatment before the surgery. So if the doctor sees that some natural teeth have a larger shift, a bigger movement, then and the space between where the implant should be placed, it's restricted or limited, they might recommend it of orthodontic treatment so they can move the natural teeth back and create that ideal space for the implant. The dentist selects the final prosthesis, the number and location of the ideal optional abutment sites, and the occlusal scheme before the surgery. So everything before, it's kind of mapping and planning before the surgery it's done. This cast permit an open discussion of treatment with other practitioners and laboratory technicians for consultation. So for instance, let's say we have a patient that's wearing dentures for many years, and the dentures are loose, and the patient decided that he or she wants implants. Now, the doctor does a treatment plan based on, the condition of the bone, and tells the patient, okay, we can place maybe 4 implants on each arch. And then in terms of the final restoration, we have 2 options. Either we can do a fixed prosthesis, so that's going to be one full arch, a bridge, or we can do denture for each arch. So the patient has to make a decision and has to be educated in what are the options for the treatment. In addition to all the data provided, they are similar to non-implant treatment evaluation. The CAST also assists in implant site selection and angulation requirements during the surgical phase. So looking at the site where are the missing teeth, now the surgeon can see if the bone shrank too much, if the bone is a little bit thicker on the lingual side or more mesial or distal. Surgical templates or surgical guides are often designed from the diagnostic cast and after diagnostic wax-up of the designed prosthesis. One set of casts might be used as a permanent record or pre-treatment condition, and usually the doctor keeps those pre-surgery cast, like the diagnostic cast, for their records. And if there are any legal issues regarding the treatment later on. The diagnostic cast and pre-treatment setup may also be used for presentation to motivate the patient acceptance of the proposed treatment. So presenting the diagnostic cast, the diagnostic wax up to the patient prior to establish the treatment plan, it shows the patient where how the restoration, the final restoration, is going to look, and it kind of puts them in that mindset to move on with the procedure. So the diagnostic casts are mounted with an accurate record of centric jaw relationship and maxillomandibular occlusion on a semi-adjustable articulator to provide more information related to the treatment that influences the final prosthetic treatment plan. And this is very important when we use those preliminary cast, the diagnostic cast. One very important aspect is to mount the cast on a semi-adjustable articulation, and the doctor can take bite registration or even a Facebook record, and we can use that to mount the case correctly. So we can see not only what's going on in the patient's mouth in terms of the anatomy and the missing teeth sides and the bone and stuff like this, but also we have to be aware of the jaws movement, patient's jaws movement. So that's why the diagnostic cast, it's usually recommended to be mounted so we can see and perform during the diagnostic wax up of all those movements that the patient does, the up and down, the vertical movements. Also, we can see maybe we need to increase the vertical. So the vertical dimension can be increased when we do the final restoration up to 5 millimeters. And how we decide this if we don't mount the case. So the case has to be mounted in case that the dentist may say, can you open the vertical dimension 2 millimeters? So that's another reason why we need to mount the case on a semi-adjustable articulator. Very important, again, we have to look at the central occlusion, the vertical horizontal overlap, and the maximal intercuspation, which is defined as the complete intercuspation of the opposing teeth independent of the condylar position. And it's sometimes referred as the best fit for the teeth regardless of the condylar position. Maximum intercuspation is the complete intercuspation of the opposing teeth independent of the condylar position. It's the same concept. I put it in the presentation because both books, Carl Misch and U.S. Air Force, has the same definition. Centric occlusion is a maxillomandibular relationship in which the condyles articulate with their respective disc and anterior superior position of the glenoid fossa against the articular eminence. Centric occlusion is the occlusion of teeth when the mandible is in centric relation. This position may or may not coincide with the maximal intercuspation. It's very important to note here that there are more and more trends in the dentistry about using sometimes a centric occlusion or a centric relationship when mounting the case instead of maximal intercuspation. And that is referring because sometimes when we do a restoration, we don't realize that if the restoration looks good to us in the model, in the articulator, when the patient performs its oral function, if the restoration is a little bit off on the occlusal side, that can also trigger problems with the temporomandibular joint. So there are some trends in the industry today that for some patients, for some cases, will be beneficial to also take into account the centric relationship when um, a big restoration is done. So what are the radiographic stents? They are used to provide a guide for the oral surgeon where the implant should be placed, and the dental technician has to fabricate the denture stent that will be used for the CAT scan. The radiographic stents are usually used for either complete denture or partial denture restoration, and they can be they're usually made of clear acrylic, and then they have this type of radio um, opaque material that it's put on the teeth of the dentures to indicate the possible positions of the implants. Okay, so there are different designs depending on how large the edentulous area is, such as for partially or full edentulous areas. There are different methods of fabrication, such as using the vacuum forming procedure and materials, or using a duplicated patient existing partial or complete denture in clear acrylic, and then applying those radio opacity materials. So, according to the Air Force manual, the fabrication of the radiographic stent using the hands-on method goes by this. So the stent it's made to determine if there is enough bone uh, available where the doctor will like to place the implant. Radiographic templates are used in the radiographic examination or the scanning. So the patient is sent to take a CAT scan, and it's using the radiographic stent, and that's going to record a picture or a scan of the patient wearing that clear acrylic denture, and then where the markers are placed, that will indicate where the bone is stronger for placing the implant. The template can help to show the amount of bone available for the implant fixture by comparing the known size of the metal component in the templates to the amount of bone shown in the radiographic stent. Metal rods also can be positioned through the center of the proposed restoration. So instead of using those radio opaque material, also we can use a metal wire inside the clear acrylic denture to indicate during the scanning where the implant could be placed. So the steps for the fabrication of radiographic template. First, articulate the diagnostic cast in maximal intercuspation or use the bite registration provided by the dentist. Perform a diagnostic wax-up. Denture teeth might be used or a full contour wax-up. It's performed. After the wax-up is completed and evaluated, it's a good idea to fabricate a tooth position index with a silicone putty for later use. So using a lap putty, we can take an index of the waxed cast. Fabricate a vacuum form template of the duplicate cast by using a clear template material. Trim the template to just below the gingival margin of the existing tooth and include all the diagnostic wax up areas. After the template is trimmed, lightly aerate the areas that are the edentulous on the diagnostic cast. Remove the wax up from diagnostic cast, survey and block out any undercuts on the edentulous area of the cast. Apply a separator on the diagnostic cast, mix the self-curing clear acrylic, and fill the edentulous area on the template. Place the template into the diagnostic cast and ensure that it's seated properly. Acrylic is cured, trim the excess acrylic smooth and polish. The dentist will clearly mark the position of the implants on the diagnostic cast. Place the template on the diagnostic cast. The marks for the position of the implant should be visible through clear acrylic. Carefully draw a hole in the side for each proposed implant, and the hole must be at the same exact location and correct axial inclination of the proposed implants. Place a metal radiographic indicator into each hole and seal it in place with acrylic or glue. Now, so in other words, we can do a radiographic stent using a vacuum forming method. And this is an easy and a faster way to do it. So we can see in the pictures where in the picture A, we see where the patient has the missing teeth. We use the denture teeth to place the diagnostic cast, to place them in the diagnostic cast to kind of mimic how the patient is going to look with the final restoration. Then in picture B, we have taken a lap body matrix or index of the cast with the denture teeth, and then we fabricate the vacuum former, and then placed on the vacuum former also we can fill up the areas where the teeth are, missing teeth are, with acrylic, and then we can drill the holes and put the radiographic material in there. So when the patient goes for the scan, the CAT scan, that's going to show into the scan. All right. So the most used method of fabricating the radiographic template, it's actually using a dental flask method or a jig method, because first of all, it's a little more accurate. So the first thing is to have the patient's denture duplicated. So for that, we're going to use a flask. And also we can use a self-curing acrylic resin that can be constructed quickly and, like I said, very accurately. The denture flask method uses the following equipment and materials which are readily available in the dental laboratory. Mandibular denture flask, alginate impression material, also can be maxillary denture flask, utility wax or orthodontic tray wax, tooth color acrylic polymer, and reline or repair surf acrylic, curing acrylic, which is monomer and polymer, the liquid and the powder. So the method it's like this. Cut a large rectangular or a square opening in the rear part of the lower half of the flask. Sprue the denture by rolling strips of utility wax together to form sprues about 3 inches long and half an inch in diameter. Attach the sprues to the lingual surface of the mandibular dentures and the palate surface of tuberosity area and the maxillary dentures. It's kind of like the same principle like you do the processing of denture through the induction method. Draw the ends of the sprues together so they can meet in the center. Apply alginate adhesive to the inside of the flask. This adhesive will retain the alginate in the flask during the later processing steps. Also, coat the lip of the knockout plate so it can be firmly attached to the exterior of the flask. So the adhesive acts like a glue between the flask and the impression material. Mix the alginate for the lower half using a mechanical, using a spatula. Um, it says here vacuum mixing is preferred over the hand mixer. If we use a vacuum mix for mixing the alginate, we have to be very, very careful on the time because once we start mixing the alginate starts to set fast. Coat the tissue surface of the denture with an alginate, being careful to minimize voids. Fill the interior of the denture with the alginate. Place the remaining mix of the alginate on the lower flask. Set the denture in the alginate-filled flask to make sure that denture's borders are covered. And so, in other words, apply the alginate material, impression material, over the denture and make sure that every undercut or every detail of the denture is covered by the alginate, okay? Let it set for 15 minutes. Assemble the upper half of the flask and make sure the screws extend through the opening. Mold the sprue wax extensions over the opening to create a leak-proof seal. Make a larger mix of alginate for the upper half. So the lower half was filled and we let the alginate set, and now we prepare for the upper part. We always have to let the alginate, the first pour of the alginate set, because if we're going to apply alginate on alginate, they're going to bond together. So first, for the first lower part of the flask, let the alginate completely set. Sometimes it's indicated to put a thin coat of Vaseline and then, continue with the upper part of the flask. After the upper part it's set, the alginate is set, carefully separate the flask and remove the denture. Use a gentle stream of air or tissue to remove moisture from the tooth imprints. Mix clear acrylic using 2 parts polymer to 1 part monomer ratio. Pour the resin mix into one screw hole until it fills the other screw. Use a vibrator to pour up the acrylic. Attach 2 mounds of clay to the front of the flask so it stands upright. Half fill pressure pot with warm water, 110 degrees Fahrenheit, and place the flask in it. Cure the denture at minimum 15 pounds PCI for 10 minutes. Recover the duplicated denture, disprue it, and finish and polish it just like a normal denture. So this is my preferred method of duplicating a denture. It's a little bit easier, more accurate, and much cleaner. Okay, so what we need for this procedure, we need a denture duplicating jig. We need a glue or a tacky liquid, and we need some form of impression materials. So the first thing will be to have the patient's denture. We can put a thin layer of Vaseline over the dentures. So then we'll take, so the jig has 2 sides that can both, they both will gonna be filled up with the impression materials. So in one side of the jig, first we start applying the tacky liquid. We let it set for a few minutes, and then we're gonna mix the impression material. Usually it's alginate. Fill up that half of the jig with the impression material, and then insert the denture inside. Leave a little bit of a border exposed from the denture. 2 to 3 millimeters of the border should be exposed, and then do the same procedure on the other half of the flask. So use the talcum liquid again, let it set for a little bit, fill up with the alginate or water impression material that you're using, and then close the jig over the denture and let it set. Once the alginate is set, you can open it up, take out the denture, clean it up, give it back to the sterilizer, give it back to the patient, and then fill up the indentation that's left inside the jig with a clear acrylic, cure it, heat cure, using a pressure pot and hot water, and then we can apply those radiographic materials like we see here. The gutta-percha points are used for root canal treatment, and they have a property that they're can be seen through X-rays or scan. So we apply the gutta-percha on each of the denture teeth, or how the doctor asks us to design where to place them for the implants placement. And that can be also, once we finish placing the gutta-percha, the radiographic it's finished, it can be disinfected and send it back to the patient and use it for the CAT scan. So we see also another method when we can use clear acrylic to do the stent. So again, the same idea, articulate the diagnostic cast in maximum intercuspation or use the bite registration. Do the wax up, the diagnostic wax up, or use denture teeth where there are missing natural teeth in the patient's mouth. Take a silicone putty or a matrix of the patient's diagnostic wax up, and then use clear acrylic, cut off the teeth, the denture teeth, use the clear acrylic, put it into the matrix, and then insert the matrix into the model and cure it in hot water or under pressure, in the pressure pot. Once it's set, you can remove it, trim it, and polish it. So radiographic stents also can be used as surgical stents. The only difference between radiographic stents and surgical stents is that the surgical stents also are used for patients where they still have natural teeth. Radiographic stents are used mostly for patients who have using, they have large edentulous area, or they're wearing partial dentures or complete dentures. So what's important in developing the design of surgical guide is to kind of evaluate the existing denture to see if it meets the functional and also the aesthetic demands of the patient. If it's something that needs to be adjusted, that's the time to do it. And then duplicate the denture in clear acrylic using the conventional methods. And now the dentist will mark the places on the denture where the implants might be placed, okay? Cut the holes or slats inside the stent, and those holes actually it's going to be used by the surgeon to drill into the bone, okay? There are different type of surgical guides. So we see that we have tooth supported guides or templates that are used when the patient has natural teeth, and the surgical stent, it's stable because it's placed on the natural teeth. Um, Also, we have what's called, I'm looking here, I'm sorry. Okay, so this is it. So tooth supported guides that are most accurate and easy to use, and those are supported by the natural teeth. Then we have bone supported guides where the surgical stent is um, anchored into the bone. Okay, so there are some cases where the bone needs to be reduced. There are certain practices in implantology where sometimes the doctor performs a bone reduction to flat up the surface of the crestal ridge. Okay, so the surgical guide can be bone supported, and that should give a little more stability. Okay, and this is for the patients that they have large area of edentulous arch, or for patients that are already using a partial. Okay, and the soft tissue guided stent that are usually indicated for patients who are wearing dentures, who they have no um, natural teeth left in their arch. Okay, and the problem with this, it's very hard for the surgical stent to be fixed in the position and to be stable. So therefore, those surgical stents that are using tissue um, as support, they're using those pins that are actually attached um, into the soft tissue, allowing the stent to be more stable. Okay. Also, most of the time today, um, the surgical stent it's done using the CAD/CAM system. And what's nice about it, in using this CAD/CAM technology allows us actually to combine different um, images. So we can have the intraoral scanner from the doctor. We can have the CAT scan added to the patient's file. And by using those scans, we can see where we can place the holes for where is the ideal place for placing the holes in the stent. Okay, so this is a very crucial step forward, because and during this process, when we design and choose the implant selection, the size of the implant, the position of the implant into the bone, we design the stent, and before we go into production, before we manufacture the stent, actually the design has to be approved by the clinician. So we cannot go ahead with the fabrication of the stent until we have the approval from the doctor. And this is done via, the software, the computer software. It's kind of like an easy way of communicating with the doctor about, the case. But this gives more control and of the treatment plan and also where the implant should be placed. Sometimes we may see that from our perspective as restorative um, aspect, we may place an implant in a certain position, right? We may place it straight, But if the surgeon looks at how we um, design that stent, they might say, you place that hole in a position that it's not very convenient because it's either a nerve in there or the bone is not strong enough. It could be that the tissue is very thick. So there are certain clinical aspects that we don't see that the doctor sees. So this approval of the design is very important into creating a final restoration that a placement, first of all, of the implant in the correct position, and also um, fabricating a restoration that's going to be functional. So these are different designs um, of the surgical stents, and this is how they look in the mouth. So where we see the holes, this is how the dentist was going to use the drill and to drill the holes and then place the implants, okay? So um, when we're using the CAD-CAM method, we have also different options in terms of the fabrication. So we can print them, 3D print them, or milling, okay? And that's depends on what we choose to do based on the equipment that we have in the laboratory. And that's about it. If you have any questions, please let me know. Thank you.